And Jamie's going to kick us off today for today's call.
Yeah, good morning, everybody. Hello from the ATL. I'm down in Atlanta. I'm excited to see you this morning and get to share this next part of our series together. So we'll dive right on in. So today we're going to talk about evaluation and the organizational assessments, aka OAs, and really excited to open up this discussion as the OAs are a really powerful tool to help guide the CQM programs at the AA and provider level. And we can go to the next slide, which I think is just a quick little Zoom reminder in terms of how you can view things, and to please put yourself on mute. But feel free to ask questions at any time by unmuting yourself or using the chat. And again, we'll be recording stuff for folks who maybe have the day off or have some issues joining a little late. I want to get into our objectives because there's a lot kind of going on, as Julie said, but it's all really exciting information. So what we're hoping to achieve by the end is naming those common components of an evaluation. And one of the benefits of using the organizational assessment is it really helps break down into, I think it's 7 domains of that program evaluation. And we really want to tease out specifically in a really concrete way how the OA provides that backbone for your AA regional quality management strategic development. We can talk a little bit about the connection between AA level and provider level OA implementation. Then once you do an organizational assessment, right, what do you do with those scores, and how do those scores become your roadmap? And we've got some tools. We have a lot of great resources in the training toolkit today to support the AA and your funded provider organizations based on what comes out of those organizational assessments. And then Michael specifically is also going to talk about how we can apply Achieving Together as sort of that overarching framework for your strategy, in combination and in alignment with those organizational assessments. And I believe we're going to head into a poll as the next bit, and I might turn that over back to Michael.
All right, thanks, Jamie. And we definitely do have a tall order today. So let's dive right in and think about CQM evaluation as our backbone. And as promised, we do have some polling questions. So let me go ahead and get that going. Launch the right ones, right? How frequently do you evaluate your CQM program? Just select one. More frequently than annually, maybe every 18 to 24 months, less than every 24 months, or you have no idea, which is okay. Next question. What components weigh into your CQM program evaluation? Select all that apply, multiple choice. So, if it's not applicable, it's not applicable. But, there's a lot of different things that we're going to be talking about today that you could put in your CQM evaluation. So we just want to get a sense from you in terms of what are the things that you actually do have for your CQM evaluation, if you do have one. So we'll wait just a moment for folks to let those votes come in. We'll go ahead and share those results once we get enough of you voting. All right, I'm going to end this poll and share the results. So it looks like most of you do an annual CQM program evaluation, which is fabulous. And we'll be talking through the different components that you use, and we'll be providing a framework for the components that we recommend in terms of having for your standard CQM evaluation. And we'll also talk about the timeline as well, because there's definitely room for nuance there. In terms of thinking about what's included in your CQM program evaluation, a lot of the work plan progress and CQM performance results, that's great. Those are the low-hanging fruit in terms of what it is that you're doing and the measurement that kind of comes just in step with your program. But it looks as though we do have some other items that work their way in as well, including the organizational assessment, which Jamie said we're going to be talking about today, and our QI project findings. So I'm going to take this down. Thanks for participating. And we'll move on into the presentation now that we've seen a little bit what some of the activities currently are in the field. So this is our handy dandy slide that we always like to show in terms of how this works in Texas, because you'll have that additional layer of administrative agencies here. And as you know, the guidance and direction flows from HRSA through DSHS through you to the provider organizations, and then the provider organizations do their work, right? And then that information rolls up from the providers to you. You aggregate that information at the AA level. DSHS aggregates all the AAs, and then HRSA aggregates all the care activities happening across our 50 United States and the 7 territories. So it's just really important to remember that where we're fitting in this picture, that we have an important role in guiding information out and then in collecting and rolling information back up. And this information isn't just the care process utilization, but the outcome information importantly as well. The so what? What happened because of the services that you provided? So, you know, just a reminder that we have these handy dandy contracts, which are important tools for our ability to do our work and to have a framework that our work occurs within. So, you know, for these contracts that you sign at the AA level and that you pass through to the providers, just a reminder that we have included this. The state has included this in their thinking around what makes for a good quality program, and that folks have the expectation, they sign the dotted line. I know and expect and understand that I'll be participating in annual program monitoring. Now, when we say the word monitoring, we oftentimes think about, you know, more the compliance side of things. And it's important for us to remember that there is that compliance side of things in quality too, right? Because people did sign that they would have quality plans, that they would collect quality data, that they would do a quality project. So it's important for us to remember, you know, when we're thinking about our role in evaluation, you know, from this piece here, did people actually participate in all the different things that we laid out for them? And how are we going to calculate or monitor that? How do we describe that from a compliance standpoint, separate from the quality process? So just a reminder that folks did sign that line. Here's another thing that we have been showing in most of our trainings with you from the IHI Sustaining QI white paper. And what we see here is the red bar is our level as the AAs. And then the green bars are what this means for us in terms of our activity at the AA level for this evaluation piece. So as the AAs, we provide coaching on standard work and on the activities that happen at that provider level. We monitor our staff and processes, but we also monitor their staff and processes to a certain extent that's appropriate and that light touch. And we monitor their standard work by collecting information in ARIES and by providing reports and discussion items with them. We also negotiate goals, and then we launch and prioritize projects as our region for what happens at the provider agencies. So it's important that all these different concepts, these different dictates or requirements that you have as an AA for your provider, every single one of those items are things that are evaluatable. Did they do it? Yes, no. What was the result? Did they like it? Did we like it? There are so many different ways that we could be doing evaluation. So then it's important, once we know what we can evaluate, what should we evaluate and how should it be evaluated in a judicious way that gets us information that we can use for our programming, but doesn't drive people insane. Because of course, that's the complaint that we hear the most as government, right? Public health run amok, yarg. Don't you know we're trying to provide services here? Isn't the most important thing saving lives? And the answer is yes. But we do need to have a framework where we can look at what it is that we sought to do, how we did that, and what it all meant. So in terms of our CQM evaluation components, the polling question was, you know, kind of a good indication of what those would be, but let's walk through. We have our performance measures, the process measures, and the results of those process measures that are rooted in compliance performance. So in order to provide case management, you know, there's all these different things that we do incident to the provision of case management, and that's what we're measuring with process measures, what we're actually doing as a part of our care process. Outcome measures are the results, the so what. So that is really rooted in CQM performance. when we think about endpoint HIV health outcomes really being a driver in terms of what is a CQM activity versus a compliance activity. But that's not to say that just because you're collecting this information administratively for compliance, that you can't also talk about that from a quality management standpoint in terms of thinking about the connection between how care is delivered and what is the result of that care delivery. So it's important to think about process measures being something that isn't really in our domain. We don't have as much control over it. That's an administrative function, right? And a lot of the things that the requirements come from the state. So we just do what the state says with a little bit of extra for our region. But we can talk to our colleagues in the other part of the AA to get that information, to tie to the information that we have. The CQM work plan, as we've talked about through other sessions, really is a wonderful place to talk about how some of these connections can occur, including the touch points that you use to be able to get this information. Do the process measures come to you from an email? Bless you, Julie. Or do they come from your internal quality management committee conversations, right? Because you have this opportunity to have these meetings with the full AA team and discuss quality issues when you have an internal CQM committee. So you can think about the work plan as an opportunity to start describing not only the what, but the when and the how for these pieces. The CQM capacity building plan really is an opportunity to start interacting with your committee in terms of what do we actually need to do from a quality standpoint to make sure that we're delivering great care and that we have a good handle on the outcomes coming out of the care that we provide. So this could be asking people to watch recordings like this one. It could be asking folks to go to the Quality Academy. But it could also be around the connection between Achieving Together and clinical quality management, as we'll be providing some examples later. The important thing is that the capacity building plan, just like any other work plan, can be designed in a way that is evaluatable. You have a schedule, calendar of expectations, a series of events, what have you, and then you just test whether or not everyone did it and what was the result. Now, the organizational assessment really is an important aspect of this as well, because, when we think about the different QI methods that we've talked about in past sessions, we have this really strong opportunity to bring in the operational improvement and the operational quality that we have in place. So we have this at the provider level, and we have this at the at the AA level, so that we can talk about what's happening at individual organizations across our region, and then what's happening at the aggregate level for our region. And I saw that some of you actually use these OAs already. But it's really, I think, an important thing to consider how you can start to use them more as a way to drive your quality program within your region, but then what's happening at the sites. And especially in terms of thinking about Achieving Together and the connection points that Achieving Together has with the CQM program and with the OA, so that you can really start to drive results and to think about this. So your evaluation components really touch the entire range of the activities that you do, from process measurement to training to your quality committees, to the QI project, and then of course thinking about the actual nitty-gritty mechanics of how this is all moving in moving pieces through organizational assessments. Now we're going to be providing more detail on organizational assessments in the next section, so I'm not going to go too much more into detail on that, but just consider them as really important elements of your CQM evaluation, because then that's how you're really driving the operational quality or the process of your quality program in your region. So we saw that there's a range of different times that you do your evaluation, and we definitely have some recommendations on what we would consider ideal. I like to do this every year, and I think that doing it every year is important because it helps to create a nice cycle we work on annual cycles anyway, right? Our grant cycle is annual, our financial cycle is annual, and so many cycles are annual that I think that it just helps to have an evaluation cycle that lines up with that. Your site visit cycle, all those cycles, right? So line them up into a clean, start and stop so that everything kind of runs at the same time. Even if your CQM plan isn't revised contemporaneously with evaluation, in other words, if you wait 2 years to do your CQM plan, that's okay. As we know, our CQM plan is a living document, right? So as we go through an evaluation that may happen twice as often as we rewrite or revise our QM plan, we have the opportunity to make small tweaks and also to create a new annual work plan that's based on the evaluation so that we're not stuck to the same stale set of activities and way of being that we may have seen from evaluation didn't work so well. So we have this opportunity to not always be aligned in our CQM plan editing process and timeline with our evaluation timeline. And it's because there are so many moving pieces that make less frequent evaluation a challenge that we would recommend not to do it more often than annually. Yeah, as I said, the annual evaluation helps you get used to yet another cycle. So like many other CQM activities, we're really aiming for something that we call just in time. In other words, we want our evaluation to drive us for sustainability. All the good stuff that happens, we want more of. We want the good stuff to continue, but also remediation. All that stuff that's kind of like questionable or we have weird bad data on, we should dust ourselves off and try again. So again, if we're too frequent, it'll feel like we're chasing our tail because there's too many moving pieces. And if it's too infrequent, it'll feel like we're standing still. So the Goldilocks really is the annual piece. I've seen some stuff come in the chat room, so I'm just going to check really quick to see, or Jamie, is there anything in the chat room that we should chat about now?
I think it's just a little bit of just a dialogue, and Julie mentioned using the OA, started using that in 2020, and it's just been helpful again to know where to start and where to aim your efforts. So thanks, Julie. Great feedback.
Awesome. Yeah. So the more that you get used to doing those types of evaluations and cycles and discussions, I think the stronger the system will be, and the more confident that you'll feel in discussing these types of issues with your providers and also internally in the AA. So what do you do with all this information? I like to actually create an evaluation report. I don't think that it needs to be like a 60-page long thing. I think actually you can just rely on minimal narrative. Since a lot of the things that we talked about are related to work plans, related to whether or not things happened in the timeline that we thought they would, and whether the result was expected, we actually have ourselves set up for a lot of really great graphics, right in the way that we have designed this from the outset. So we don't need that many words. Words and the narrative should really be used to emphasize the most important findings or the most important observations based on all of these different graphics and other visual materials that you would have in your CQM report. Tying findings to recommendations for the next cycle is really important because this isn't something that just sits with you. This is a discussion tool. You use this tool to discuss with your internal CQM committee and your external CQM committee. You can even use this if you work in an area that has planning councils. You could share this with a planning council. If you're a fast track city, this could be shared with the fast track city task force. If you're part of any other learning group or network, it could be shared with them just for the conversational opportunity to pick through. Are all the observations and all the findings that was important to you as a CQM professional or your colleagues in the AA the same as the findings and the revelations that occurred to the people providing services in the field? If you do have people living with HIV who are trained and ready to participate in these types of conversations, it's a wonderful way to engage consumers as well. because talking to them about, the way that the system is set up, the care that's provided, and the outcomes that we get from that care are really exciting to them because it's about their lives and their livelihood, right? So thinking about trying to drive any stakeholder discussion to lead the next cycle's activities is a strong thing. And the more that you can think expansively, the better. Sharing is caring, but it's also one of those things that helps you to glean information beyond what you yourself can think of. And we all come to life and come to work with our own sets of experiences and biases that it's really important for us to be aware of and to try to work around through conversation. And the conversation is set up by having this report. So overemphasizing graphics and visuals to present the data so that you can really limit the narrative to recommendations, and those conversation points is the name of the game. And basing your evaluation on program priorities, the vision and mission of your AA organization, or anything else from a strategic standpoint is good, right? Because that's strategic thinking and strategic action, so that you're not necessarily confusing complicated, contradictory information. You're always going back to your own North Star in your organization, which all of your organizations have visions and missions. So think about what is really important to your organization, and then how to present that to your stakeholders to really drive what is your common goal. So how do you do that? Facilitated dialogues and a call to action really is the way that you do that. I think that we've all been in that place where we get a report that I'm sure is interesting, I'm sure has information that would be helpful for me, but in the face of getting all these other reports landing on my desk and being told, read this, it's really hard and it's overwhelming. So being able to have people come together to say, of all the many things we did this past year, what feels the most important to you? And is anything not important? That discussion is actually more important to them than the report itself. So again, that's one of the reasons why we want to de-emphasize the narrative and to emphasize the graphics, because that's how you get people engaged. They'll see something and say something based on what they see. Presenting evaluation data can be tricky because, as we're discussing, it can be a lot. So it's really important to be judicious and, again, to think about the strategic positioning of your organization as an AA and how it's providing services and what those services are designed to kind of to produce in the area. Ask them, based on the data, what can we do differently next year? Did we over or underdo it in any area? Are we all appropriately trained? Do we feel ready to have these conversations? Are we all at the same starting point, or do we have various baselines that we're starting from? Sometimes you can create smaller discussion groups that will help you cover more ground faster. So thinking about Achieving Together in particular, and the special populations that you may be targeting within your region, that's a great example. Provider organizations that work predominantly with that target population, another great example. Or sets of services that are really important to the care continuum in your region. And I'm looking at you, let's see, the STDC, BVCOG, and STAR, because your areas are so large, it's really important for you to be able to drill down and to crack that nut by having conversations that are meaningful to the people that you invite to them. And what we know when we have a really huge, expansive region is that, the information we present will only be interesting to a couple people at a time because of our largeness. So the more that you're able to be pointed and to be directed in the way that you engage people and ask these strategic questions, the more they'll feel seen, the more that they'll feel heard when they do share. And then when you go back to them with results, it creates an upward spiral of participation instead of the downward death spiral that we're all accustomed to. Aha, I got ahead of myself, but let's reemphasize this. We're all different in Texas. Our AAs are different sizes. different geographic spans, different cultural nuances among the populations that we serve in our different areas. And I think what's really important is that we remember evaluation is for everyone. And it doesn't matter if you're big or small. It doesn't matter if you're urban or if you're rural and kind of spread out. Evaluation really is for everyone. Now, the robustness of information and inclusion of stakeholders will vary across our different types of AAs. So the A-B perfectly overlapping AAs would be one group. And the way that you think about this is going to be way different from the Part B AAs that have no Part A core, or the Part B AAs that are expansive but still have a Part A core. It's really important that we think about the different groups that we invite to have these conversations and the information that we share back to them. We're not going to have, thinking about any of these groups, we're not going to have a single slide set that we share that same slide set to 12 different groups of people. No way. The whole purpose is to provide something that's really customized to that group of people. So just think about that. When we think about this laundry list of things that we could include in our evaluation, what should we include? And what's timely to present to what group when? All right. So we know that this can feel a little hazardous sometimes having some of these conversations. So you'll notice that we have our caution signs and we have our fun polling pictures that really are also kind of tools that we use in helping to caution each other. So I'm wondering if this is a good place to kind of pause to see what questions or concerns you have. And Jamie, was there other stuff that came out of the chat? It looks like not yet.
Yeah, I haven't seen any new info. It would be interesting. I know Julie shared that Part B has started using the OA. So, you know, if other folks have that experience, it would be kind of interesting to see, you know, who's maybe dipped into it, or, you know, they know that that's coming down the pike. That would be interesting. But
so
oh, sorry. Go ahead, Julie.
I just wanted to say that Michael helped us develop a chart where so when you use the organizational assessment, it has a score depending on where you land, right? And then you can add all those scores up and have one score so you know like what you want to work on next time. But we did this with all of the 7 administrative agency organizational assessments to see where the most frequently occurring low scores are, so we can really focus our efforts. And that was so helpful because there's so much to do, right? And we can't do everything at the same time. So being able to prioritize using data and using a systematic approach was amazing. So thank you for the tool. And I hope, so all of our AAs have done it already as a self-assessment, and then we do the assessment as DSHS, give it back, and then we try to work together to figure out a plan moving forward. So I know all of you have experienced this. Can anybody share any of their thoughts, or if it helped them to see things about their program they didn't know before or weren't sure, or help you identify what you're supposed to be doing as far as the HRSA expectations? Everyone's shy today? All right.
Noah, were you going to share something before?
Yes. I apologize if there's background noise. There's a lot going on. They're preparing for a conference. So all love. We're in we're kind of like a shared workspace. So it's just like a lot going on here. So I just kind of wanted more comment. I think it's difficult to get buy-in from your organizational, the operational and the qualitative, right? So the needs of the agency itself on short staff, you know, overworked. When do we put in these trainings? When do we actually get them to complete these trainings, right? Without being that person, how you said, like, oh, here's another training, work on top of work, and then aligning it with the state needs, and then aligning it with your national needs, right? So I think that's where, at least as quality management and operational, that's where I see the most barriers.
Thank you for sharing that. I think that that's not uncommon You know, and one of the main tools that I've used in the past to help with this is the creation of a curriculum, so to speak. And that would be, and we have examples we'll share at the end of this call if there's time. It's definitely in the toolkit. But you'll see how we can create the system of minimum expectations. And then over time, we can take this out and talk about it with our stakeholders. This is what we've all agreed on, is our minimum expectations of ourselves. And you can think about this from the AA level, the provider level, the consumer level, and any stakeholder. You create this matrix basically that has the types of content and then what the types of person and then the types of content that type of person should have under their belt. And creating this process then by which you conversationally check in with people to see what their needs are, as opposed to having forms and, you know, all of that stuff that kind of feels like extra. Sometimes it is just extra. You know, so having that conversation with your stakeholders about, well, we understand that everyone's busy. So what is possible? What can we do if we can't have it all? And unfortunately, you know, we all want to have it all, but we know we can't. So let's be realistic together and explore it together. And I think that the tool that we'll share is a really great starting point for that discussion, because you can be like, this is in, this is out. What about this group? What about that group? You know, and you can kind of approach it in that way. That's great feedback, Nora.
We do have a question in the chat. I want to say hi. Hi, Brooke. Brooke just had a quick question about where to find the toolkit or the OA tool and some of the other pieces.
Oh, Julie has an announcement, I think.
Yeah.
Yes, I am so happy you asked that question. I just got an email during this presentation, the beginning of the presentation, that we have been approved. We've been working on our DSHS CQM website for a couple months here and there when we have time, and we finally were able to send it up for approval, and it looks like it got approved and it will be on our site. I'll put the link in the chat in just a minute. It should be up within the hour. And on that site, we'll have recordings of all of our sessions we've done so far. This is the fourth one of the 4 series of leadership around CQM. In May, we're gonna restart them around projects, CQ quality improvement projects, and how to align your work with ending the epidemic work, so you're not chasing your tail trying to do 2 different, very similar, that you can completely align. There's some other tools on there. There's a fishbone diagram, a blank template, and then there's an example of how to use a fishbone and a driver diagram and a whole bunch of links to a whole bunch of resources. And again, including these recorded trainings with Michael and Jamie and Jasmine and a bunch of other stuff. So I'll put that in the chat in just a moment. So thanks for asking.
Fabulous. Thank you, Julie. This is really great because we'll email the toolkit tools to you as well. But of course, over time, it gets lost in the jumble. So one of the main things that you'll see also is it's a good recommendation for us to have websites as AAs where our own providers can come and see what's up from that lens. You know, some of these documents that we're talking about, like that capacity building plan, like simple expectations, but also the tools, processes, forms that they can use for their own quality improvement projects. By having this all in one place, that's another way that we can help to get around the issue that Nora had mentioned. Making it easier for people to find the tools and resources they need is something that you can do to really help to take that pressure off of them. It also helps to cut around the end game. You know, when some folks are the kind of complainy, excusey types, you can be like, well, I'm sorry, it's all here. Can you click this link for me? You know, and not to be, mean about it, but like after a while, it's like, it's all in one place. We're crying out loud. So that's really great, Julie. It's really exciting. Yay. All right. Well, I'm going to turn it over to Jamie to take care of this next section on organizational assessments.
Thanks, Michael. So as we think about this OA conversation, we kind of have 2 swim lanes. We have the AA level or OAs to think about and a provider level. So we can dive into the next piece. And we do have a poll. some polling questions. All right, so let's talk. Have you made any changes to your AA CQM program based on AA level organizational assessment in the last year? You know, we know folks have maybe begun using these. So yes, no, or I'm not sure. Select one. And then a second question would be, on what frequency do you conduct an AA level OA? Maybe that's every year, every other year, some other timeline, or we don't routinely do OAs. And then last, we have a third question about the provider level piece. Do you conduct provider level OAs in your AA? Yes, no, or of course, I'm not sure. We've got about 7 people of 17, so we'll wait a few more seconds to bump that number up to closer to like 75% or something. Maybe look for a few more votes. All right, let's share some results. Okay, so in terms of if folks have made changes at the AA level based on the AA organizational assessment, it looks like we do have some folks who said yes. It's kind of pretty fairly evenly divided though between no or I'm not sure. And then in terms of frequency, you know, this is something we can talk about, right? How do we bake in that sort of routine OA assessment? That might be, you know, really helpful for today's conversation. And then in terms of conducting provider level OAs, we maybe have, you know, a majority of folks who aren't really sure, which is totally okay. We got to take things one step at a time. And then we do have somebody, so it'll be interesting as we talk about provider level, if that individual is open to sharing. That'll be cool. One of the things I like about this is that as AAs, there can be peer exchange and peer learning, you know, with recognition that AAs are different, but where are there opportunities to leverage what each other is doing and sort of learn and share from that. So let's go to the next slide. So we want to just talk about the basics of the organizational assessment. And this is applicable if we're talking about doing this at the AA level or we're talking about doing it at the provider level. One of the key pieces to keep in mind is, you know, this is a validated tool. So validated meaning, you know, it measures what we expect it to measure. And it's a reliable tool, meaning every time we use it, like regardless of who's doing it, it's going to measure what we want to measure. We can sort of repeat it over time. So it's okay if our AAs are different. It's okay if our providers are rural versus urban. Like it helps account for all those pieces, which I think, you know, in your position, you can sometimes be asked to juggle a lot of things or kind of make exclusions or exceptions for people. But using a validated and reliable tool helps kind of ease all that off your plate and gives you a spot of consistency to work from and just help with prioritization and where you aim your energy, kind of like Julie and others were talking about. So the OA is a validated tool. It's rooted in the Baldrige Award methodology. So this was created by HAB, the HIV/AIDS Bureau, and they worked with the National Quality Center, who is now CQI. There's a report that we can share with you for your own learning, but also for your own advocacy as to like why to start using this piece. It's been validated by JSI through CQI, aka formerly National Quality Center. And again, the OA really helps frame the components of CQM excellence, and they break it down into domains, which is really nice. The domains cannot be clustered, but they can sort of be grouped together. And we'll talk about how you can look at grouping when you look at sort of that final summary, how you can look at grouping in terms of your work plan, so you get the most bang for your energy and efforts. There are standard next steps for Ryan White HIV/AIDS program CQM sophistication. Again, the OA is your friend because it becomes that backbone for your planning. And there are various formats for the different parts of funding. So again, in the toolkit and here in a moment, we'll break down kind of at the AA level, what does the assessment look like? And then at the provider level, what does that look like?
And we have a hand up.
Oh, cool.
Nora, would you like to ask your question?
No, this was for the previous question.
Oh, okay, cool.
I forget to take my hand down like all the time. No, whatever. The Zoom world. We can go to the next slide. Thanks. All right. So in terms of OA scoring, so this is something to definitely keep in mind, right? Scores of 3 are considered compliant. So this is where you want to start with. Whatever the question is, this is kind of where you want to be. This is based off of, HAB expectations, also policy clarification notice 1502, which is like our little CQM cliff notes in terms of what we're doing and why we're doing it, right? So that's where the 3 is. And that's why you want to start there. That's kind of the ground floor of where you want to be compliant. Scores less than 3, let's say folks on something related to performance measurement or consumer engagement, maybe folks score less than a 3, which is okay, because that becomes the place for corrective action. That becomes the place for recommendations and sort of where you put your energy. Another thing to keep in mind, and we'll see some visual screenshots here in a minute, is you want to have all your boxes checked. And this tool actually, I think, creates a great opportunity for dialogue. People can self-assess it first, and you can have a conversation. All right, well, to get a score of 3, we need 5 boxes checked, and we know we can't do that. So where do we think we're at, or what piece are we missing? And you can have some organizational consensus in order to get that score. Another cool piece is that the OA doesn't have to live in a vacuum. There are crosswalks available to show that relationship between PC and 1502 and how the OA are related together. And one of the things that we've seen be successful, and we would encourage, is to add contract requirements as sort of a third type of column in a crosswalk, so that as the AA, you see, here's the assessment, which outlines a lot of great expectations. Here's what we know is relevant to PC and 1502, and here's what we know is relevant to us, us specifically, and our contracts and our relationship and our, signed agreements with people in our jurisdiction. So again, just keep in mind when you're actually using the tool, start with a 3 and either work forward or backward. And when you work backward, just explain that the goal is to bring the performance up to a 3 as soon as possible, because again, that's considered compliant. We can go to the next slide. So at the AA level, we use the Part A organizational assessment. So as you open the toolkit or you access things online, you actually want to start with the Part A, which might seem counterintuitive as opposed to the Part B. We use this Part A organizational assessment because it reviews the system of care and care network. And it reviews the way that your system would promote quality or help drive those quality outcomes. So because of that systems piece, that's why we apply the Part A organizational assessment. At the provider level, it's slightly different, right? Which is great. That's where your Part C/D assessment document is going to come into play. And it reviews the provider organization. We'll see here in a moment some pieces that are really meaningful and value adding of that assessment, which is why we use it at that level. So it's going to go over sort of the way the organization themselves promotes quality and helps drive quality outcomes. So we have an organizational level versus a systems level. The AA organizational assessment builds upon the provider organizational assessment. And that's why we still want to do it at the OA level, and then sort of in parallel to that, have folks doing it at their provider level using the Part C/D assessment. So, keep in mind, we sort of represent the sum of our parts, right? We are a system of care. So OAs at the provider level kind of help direct and drive up the things that happen at the AA level. And that can relate itself to what kind of TA, what kind of ongoing resources, what sort of sources, communication channels. Michael shared that visual earlier that showed the relationship of like HAB to the state, to the AA, to the provider, but it was a two-way street, right? And then we have things that roll up. So in that same way, we're the sum of our parts. And OAs at the provider level allow for those advisory groups to weigh in, the boots on the ground, the cabs, the PACs, the other pieces to weigh in on the system level priorities to help direct. So again, it's a two-way dialogue and it's an interrelated relationship. Another point of leverage is that AAs can work together to develop training sets and action steps. If across all the AAs, we realize, hey, within the performance measurement domain, we're all rocking like a 2.5, right? So how do we create something that's maybe a training set or something like that? And again, kind of to Nora's point, that helps with turnover, capacity, and directing resources. We can work in coordination with each other on areas where, you know, we collectively want to raise that score beyond a 3. And DSHS can provide a set of materials also to help direct AAs and their funded providers as we think about achieving together and the sort of specific provider level activities that enhance that approach. We can go to the next slide. So here is a snapshot of what in the world is the difference at a very high level between the AA level organizational assessment versus the provider level. So we tease that out. Right? There's about 7 domains in general at the AA level, but once we get to the provider level, we see that within the measurement, analysis, and use of data, it's a little bit different than what we would see reflected in the OA at the AA level. And again, that's because at the AA, we're looking at systems. We're talking about systems. At the provider level, something else that's cool, and I think a great conversation piece, is it talks about organizational integration. So when we think about quality not being one person's job, right? And how often do we bump up against that in real life? This can become a space where we have a roadmap for, all right, well, what are the pieces we could do to shift that in a concrete way? Like, how do we measure that? And then how do we, you know, get some momentum toward where we want to be versus maybe where we're simply finding ourselves or we're stuck at right now. We can go to the next slide. So common elements, right? Here's a little cheat sheet. If you do well, you're likely to, like if you do well in these areas, you're likely to have that overall aggregate score shape up to be well for you. So we often see things that have to do with communication with stakeholders, whether that be your planning council or other groups. Performance measurement, you know, there's often always room to improve there, right? But how do we use our data, routinely look at our data? Who are we engaging? How are we applying that information? There's some good nuggets within performance measurement. And, you know, in my work, I've also had plenty of room to grow when I think about contract language, right? And how are we being explicit and clear as to what the expectations are, where we want alignment, what's my job as your recipient or AA, and what is your job as the person getting the money and agreeing to do this. Another domain is where you can foster a collaborative approach to providing regional health services, as well as training of stakeholders. So again, if you sort of focus on these different pieces, it helps you be more efficient. And then again, will also improve that OA score over time. You can sort of target things very easily. Let's go to the next slide. So here's an example, and you can give a little hand up emoji, clap emoji if this looks familiar to you. At first, it can look like a whole lot of words on a page, right? And I've been there and I feel that. But, well, you know, what do we know? What we know is you start with a 3, right? So you see in this example, you know, this question is, to what extent does the Part A recipient create an environment that focuses on improving the quality of HIV care? So the folks doing this started at a 3, and you can see there's a couple different boxes that would result in that score. And one of them is checked. So we start at 3, we can't check all the boxes. Let's work backward. So within the score of 2, there's a couple of things that are like, you know, this is really true for us right now. But again, not all of the boxes are checked. So we go to 1, and they're more at a planning and initiation phase. And that's okay, right? That's real life. That's where we're at. So this would be the score that the folks would receive on this, because every single box can be checked. So then when we think about what we do with this information, we look at the stuff, you know, on the next one up. So number 2, you can see these blue arrows point to what the remediation is, right? And this becomes that backbone for our planning. This becomes what we write up in our recommendations. So data definitely seems like a pain point here. So we focus on getting that data, right? Another area for growth was contracts, right? How do we impress on providers what is really needed? So get those teeth, you know, put some substance to what we're doing here, and some accountability and some checkbacks for ourselves. And then the last one would be resources, and just resource sets that are tied to the activities. It's support, it's support, it's support. We can go to the next example. to kind of keep this piece going of what this looks like in real life. So then we get to the next question. Okay, hit a refresh button. To what extent does the recipient have an effective infrastructure to oversee, guide, evaluate, and improve the quality of HIV services? Again, we started at a 3. We got one little box checked. So let's move backward a little bit. 2, we're feeling like, yes, a couple of these pieces are true. 1, can't really agree to any of it. So we go to the getting started position. And this is where we're at in terms of the Quality Management Committee or guidance to subs on how they conduct their activities. So again, you can see that the use of data is kind of the Achilles heel here. So part of that remediation, part of that recommendation would be to identify roles and responsibilities so that it's all hands on deck with QI to come up with a data review process and the timing. How do we share it? How do we discuss what's needed? And of course, to include planning bodies, some sort of infrastructure related to that in terms of your CQM and your QI, whether it be the QI planning or the QI learning piece. I want to pause here just to check and see if there are questions about this or comments, anything from the chat, now that we've looked into some sort of that granular stuff that exists in the OAs.
Yeah, I see Julie made a comment in the chat that this is all about starting somewhere, and this isn't punitive. In fact, you can see that this tool and this process itself is TA. Just by going through the tool, it's a TA process. And that's something really important to keep in mind, that this really isn't punitive. Something else that stands out to me looking at this example is that we just went ahead and skipped over 1. And we went right from 0 to 2. And it's because it's easy to put these 3 things in place to meet that 2. So keep in mind that sometimes it's good to skip over 1 if you only need to do a little bit in order to get the higher score. So that is something that kind of stood out to me. Like, why would you skip over the 1? Well, you'll skip over the 1 when you actually don't need to squeeze that much harder to get a 2. Juice for the squeeze.
Yeah, awesome. Thank you.
Other thoughts or comments or questions about this? All right, back to the show.
Yeah, we can keep rolling. And I'm glad, Julia, you said what you said, because as we go to the next slide, the idea is it's not punitive, right? This is evaluation. This is our check-in. This drives a dialogue. And I think this is really nice because people will come from their different perspectives. And so this actually can be a form of TA, and this can be what gives you space to talk about the stuff that you maybe wanted to talk about all year, but you haven't maybe had the time carved out to have that sort of meaningful conversation. So, when we get to, after the assessment's done and we want to sort of collect our thoughts, it's important you can group results by domain. And the goal here is to be solution oriented in the notes, right? So we see some different examples, and these are actually based on those 2 preceding slides. So where we found the site maybe scoring a 2 on one piece and being more at the getting started of another piece, we can see how by grouping these together, you can put that solution-oriented voice forward. So you can talk about enhancing contract language around the CQM expectations and developing additional resources like websites, templates, instructions, and tools. We can tease out about training the planning council. You can get specific as to what that looks like in your spot on quality of care or other components, and complete and disseminate the document, spelling out various roles and responsibilities. We saw that was reflected in a preceding slide, and become more data focused and leverage data outside, as another resource. So this is an example of grouping results by domain based on the way those scores actually shake out. And then we talk narrative summary. So again, this is where I think it's kind of cool to keep a sort of like a recommendations package, right? So this paragraph is really summarizing, those preceding slides. But what I like about it is it's more strength-based to start. So we see that the initial statement is that the CQM team at the agency is highly knowledgeable when it comes to the Ryan White HIV/AIDS program quality expectations and processes, right? But here's where they need stronger support. And then we go into that narrative, right? So maybe it's program leadership to be sure they're able to do their jobs effectively. Data, we talk about data being a major Achilles heel. So again, this is summarizing the themes that we've seen from multiple domains. It gets into a lack of strong contract language or reinforced expectations, providing some examples that can happen through desktop monitoring or on-site visits or use of the organizational assessment, right? And then it sort of creates a summary of those scores. So this becomes a lot more digestible than flipping through that document. It's a way for us to organize our thoughts, but also a way to be clear. And this can point out to your senior leaders or other people, you know, based on this narrative summary, here's all the little pieces that can fall in line or improve when we focus on these major themes that are put in that narrative.
So there was a question from Nora in the chat room. Does the subrecipient have the autonomy to initiate an OA process, or should they initially be working just with the AA?
So I think that the sub does. I think also if you look at, you know, what is in your contracts and what are in your work plans and things like that, but we actually would encourage that, yeah, the subs do it and that they do a self-assessment first, and then you can walk with them through it, or you can do one of them, and then that becomes another sort of talking point, like, okay, you know, you guys think you're really a 4 when it comes to consumer engagement. Like, this is amazing. Let's talk about it, right? And, you know, I think that that's an empowering tool. I think also by folks doing it themselves, it gives them sort of an orientation to it, right? So that they can process it. And it also ensures that they're working as a team or a group, and it's not just like one person filling it out at the agency. This becomes a really helpful document and creating a culture of quality, getting everybody on the same page. So if you think of performance measurement, your data person might be like, yeah, we totally do, blah, 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 blah. But somebody else has no idea because they're not involved in the data. So then again, it allows them to figure it out like internally, collectively, and create a shared foundation. That's kind of one of my favorite parts to this exercise.
Yeah, it's deliberative and it's a team-based approach, and you know, you have your internal team, but thinking about the role that the AA and the provider and DSHS, that's a way of looking at a team as well. It's a vertical cross section, right? So the way that Julie works with you all, you know, to ask you to do it in advance, same thing. You know, that's great modeling on the part of DSHS in terms of what you can do and maybe should do even as a AA. Great question, Nora.
Yeah, I love that question. And, you know, also what's cool is, you know, some folks might be more amped to initiate this, and then they become models to their other peers and their colleagues. Or if there are sites who are like, you know, they can then peer share and learn, and they sort of see someone else was able to do it. And I think that that creates a space for other folks to be like, you know, okay, you know, we can too. And that takes a lot of work and burden off you as well, because they can sort of learn from each other. Cool. You can go to the next slide. So creating a master list of those recommendations, the recommendations, right? So we want to keep it simple and package the recommendations. Again, you know, we showed a slide earlier about the different domains and how kind of collectively they can move that score in a positive way. Or we talked about grouping things, right? So are there different actions that can be taken that would address multiple deficiencies? This can also be a point of persuasion to, you know, folks above you or senior leaderships or bosses. This can also be a point of persuasion on that topic of like, we don't have the capacity, or like work upon work, right? It's about creating a culture. And if we can achieve one thing with our data, it's going to actually impact a lot of these different moving pieces, right? So this helps you get more juice for that squeeze. We also would recommend blending the master list and the narrative summary with your other evaluation data. So Michael talked to you earlier about, you know, the assessments being one piece of that evaluation, you know, sort of the world of evaluation that we live in, right? So keeping that with those pieces and not letting things trickle out as separate or siloed. And again, making sure that that OA is the backbone, because all areas that are already in that evaluation are reflected in the OA. So it makes sense to keep it in the FAM and keep folks all under one roof and keep it together, because it's going to impact what do you put on your work plan? What's part of your capacity building this year, right? How do I coordinate with my planning council or fast track people to be an agenda item on that meeting, right? It's all related. And then facilitation of reporting upward and engaging stakeholders so you can discuss where to best place those limited energy and resources. Can't emphasize that point enough. So we want to pause here. We've talked a lot at high level about evaluation and about the assessments, and then we've taken a real deeper dive into what that looks like, how to implement it, and then how to summarize it. So just temperature check, chat room check, any kind of questions or conversation folks want to have about the pieces we've went over so far.
No blips in the chat room right now, but what do you think?
Oscar, I know you implemented this in Dallas for Part A and then also used it for your Part B assessment as we worked together back in 2019 to launch these. Would you be willing to share a couple words on your experience? Sorry to call you out and put you on the spot.
And don't forget to unmute if you, I don't know if you're talking.
Maybe he's having technical difficulties. Well, anyone, please speak up. I know all of us have used this, at least at the AA level.
I'm just afraid that it's going to meet with a lot of resistance initially.
Yeah.
I mean,
Yeah.
there's, like one of my agencies has 3 staff total right now. Champs in Lubbock, they only have 3 people working. Project Vita only has 2 people, but they have a small client list. But I don't know what LaFay is going to do when they see this, because they have Part B and C. But anyway, that's just my first thought is maybe you guys could talk a little bit about strategies to get them to not look at this as some kind of new level of monitoring.
Bob, real quick, can you share your experience? Did it help you identify some areas at the AA level that stood out when you performed the self-assessment?
Well, it did have domains that I had to think explicitly about. There are some things that we do and some things, that yeah, that fits, that kind of thing. And it did give me some new ways of looking at, how we are performing our QM responsibilities. But I didn't feel it was an attack on, StarCare AA. But I have some of my providers, I fear, based on past experiences, may view it just like that, an attack on their positions. So, so just some kind of strategies or ideas on how to, provide a spoonful of sugar so the evaluation goes down. Something like that might help me.
Yeah, that's a great question, Bob. And in my experience, I think one of the ways I've seen some masterful facilitators take care of this is to really go into the conversation understanding that, like, you guys do so much with so little. This is, a change. And so it, seems like a lot. But what we want to do is to break this up into bite-sized pieces that work for your staff. And so thinking about the way that we have those different domains, the A, B, C, some of those have 1 question, some have up to 3. And so you can take a conversation, instead of having a big, long 3-hour conversation and do it all at once, you can say, let's do this in 20-minute bits and pieces on a schedule that works with you. Some of the domains might be more like 30 minutes and some of the domains might be more like 15 minutes. But if you can create a regular conversation where you have the opportunity to do just enough, just a little bit, that really helps people over that hump about what is possible, what's reasonable, what's practical, Why am I doing this and what value does it add? I think is usually the biggest problem that people have in terms of like having to take this next big bite of something. They're like, oh my God, I'm already doing so much. I haven't even swallowed what's in my mouth. Like, please tell me why I should be taking this next bite. So sometimes it's nebulous, you know, to kind of explain like here we're in this webinar talking for 2 hours. But to convince someone to come over and to see value in this process, sometimes it'll take just breaking it up in pieces. Now, I know some folks that, you know, are super strapped for time. Sending them the whole thing and say, we're just focusing on A would still be too much for them. They'd be like, because they'd see the whole thing and say, well, there's going to be a B, C, and D shoe falling soon. I don't know about that. You know, so talking about the OA process, we're going to be doing this new thing with you. It's going to take several calls over the course of a month or two. And we're going to do a little bit at a time. And just sending them those 3 questions, like from the section A in advance and saying, to have this conversation with you, it'd be great if you could have these following items available, or if you could send them to us in advance, that's great. One of the things that's really important that I think that we forgot to mention when doing the scoring is that it's really important that we, you know, to avoid what Jamie had mentioned, the idea that like some groups get a pass, there's this negotiation about what's really required, what's really, you know, expected, you know, getting around that by having a sense of what physical materials you can see that actually proves that what they're saying is true. And that's actually what happens on the ground. Because we can all do that, right? We sit back in our chair and we're like, our agency is great. Our agency does this, that, and the other thing. People love it here. We have turnover sometimes, but you know, it's not really our fault. Blah, it's the other guy. You know, we need to get out of that conversational space and to have a conversation about concrete materials. So that's the other thing too. Even if you have a large organization that might be averse to change because they're so big, they're like, I don't know how to make rapid change because I'm too big and clunky. You know, breaking it up in bite-sized pieces for those types of organizations can help too. That's a great question, Bob. And I think that a lot of folks have that concern when they think about how to launch a new thing like this.
Yeah, I was just going to say that I've had to do that before. So I previously worked at a TGA in Kansas City, Missouri, and so we'd have folks, especially our small agencies, our supportive service provider agencies like housing, you know, who got Ryan White money. You know, they were like, girl, you crazy. You know what I mean? At first. And I think part of that is just a resistance to change. And so, yeah, breaking it up into sections is definitely one strategy. And another one is that, you know, like we said earlier, evaluation is for everyone. And evaluation is part of this relationship, right? Like it's part of what we're doing here together. So how do we do it in actually the least annoying way, right? So this might seem like a lot, but what this offers folks over time is consistency. You know what I mean? We can keep checking back. There's enough here, enough substance that we know aligns with our PCN 1502 and aligns with other stuff that we can come back to this on an annual basis. And subs really want consistency. They want to be marked on the same thing. Part of that resistance to change is sometimes they feel like the goalpost is always moving. Well, this year you're asking for this, or you want to evaluate me on this, and next year it's that. So this helps us meet that other need, which sometimes drives that resistance to change. And I think just offering folks some consistency really goes a long way. And that can be sort of a sales pitch piece to using this tool and breaking it up into sections and offering them that flexibility.
Great. Angie, you have your hand up. Hi.
Yeah. Hi. I guess I would just add, I'm sorry, Julie and I spoke a second ago, but I'm trying to get my thoughts together. So hopefully they'll come out
Take your time.
the way that I'm thinking them. We've done this in Dallas for several years, but it's been a process. And when I first got there, we took the Part A tool and I tried to tweak it to fit the subrecipients.
Yeah.
But now that we are, you know, we'll have the Part CD tool that is for subrecipients, I think it'll work, you know, a lot better. we use it as part of our CQM monitoring, the part of the monitoring visit. One of the challenges was kind of like them maybe not scoring themselves the way that we would score them. I think it helps to have the data, the evidence, all the documents that you'll need, because we asked them to send us documents so that we could score it. We asked them to score themselves. I don't know, all of them don't always do that. And then for us, it's been a challenge to sometimes to make appropriate recommendations like Jamie just showed. And I think now that we have consultants helping us, that you guys are helping us, that we'll do a better job with that, helping them to apply the OA to their organization and see how it applies to the PCN. I think the subrecipients in our area were very happy to have the focus on the CQM program, and it actually helped them to get buy-in from their organization. Because a lot of times the CQM program is kind of overlooked and everybody's focused on the compliance, the program monitoring and the fiscal monitoring, and they just kind of bypass CQM. And so this kind of helps us at the AA, and it helps the subrecipient to kind of see what needs to be done. And then it kind of helps the subrecipient to go to their leadership and say, hey, we need, X, Y, Z, so that we can improve, these areas that they laid out for us. And it helps the CQM person. A lot of times there's one person doing CQM, and then that person may also wear 15 other hats. And it helps them to say, hey, we're supposed to have a CQM committee, in addition to the PCN 1502, this tool kind of spells out what you need per each box. And and it shows you a continuum. Hey, we're at a 0, but we're trying to get to a 1 or a 2, and then ultimately we can get to a 5, So I think it gives them a big picture of what things look like. It gives a little push, and it gives a foundation and some motivation and a lot of things and a strategy. So we can kind of take all these little pieces of the puzzle and put them together and see what we're supposed to be doing as far as CQM goes. I hope that makes sense.
Yeah, great point. I especially like what you said about how this kind of gives teeth to advocating for the QI part and the CQM outside of assurance. And I'll just say really quickly, you also brought up something great. Once you've done this once and then you do it again, you can sort of trend. You can trend improvement, right? So folks can be like, we've gone from a 1 to a 2, or we went from a 2 to a 3, and you can do that by domains. And that's something in Missouri, folks actually did quick, easy peasy little Excel run chart, and you could see your changes in OA scores over time. And, it starts going like this, and people feel really like encouraged by that, and it helps show all of the work and effort and coordination, and it kind of documents like the great changes and great shifts you've made regardless of where you started from, whether you went from a 3 to a 4 or a 0 to a 2. There's meaning in it, and that's a rewarding experience.
Super awesome discussion and dialogue, and I think that this is a really great it's a really great segue as we round the corner now, thinking about Achieving Together and organizational assessment, Achieving Together and the CQM program. So I'm going to pull up our next polling questions here. All right. So it's been a couple months since the last time that we all came together in December. So we asked the question then, and please forgive us, but we just want to see if there's been any changes in your CQM activities and how those align with your component of Achieving Together or US-EHE, or both, if relevant for your area. Also, do you believe that Achieving Together will be assisted by enhancing our CQM expectations among funded HIV providers in our regions? So we're just going to leave a couple of moments for people's votes to come in about these two questions. Let's get a couple more votes. All right. The votes are pouring in. All right. 3, 2, 1, and let me end. So it's really, really cool. Last time we spent some time talking in December, a lot of you hadn't quite made that leap yet to think about this. And so it's really great to see that we have 60% of respondents saying that they're now working to link the CQM activities with Achieving Together. And there's a couple who are still waiting to round that. But I think that the other thing that's really encouraging here, super encouraging, that you do believe that by enhancing your CQM program, that will make an effort or a dent in Achieving Together. And I think that that can't be understated, right? Because if we don't believe ourselves that our work is going to be meaningful and impactful, then it's going to be really hard to convince other people in the field that it's going to be meaningful and impactful. So it's great to know that we do have, you know, the Kool-Aid, so to speak, has been drunk internally among us. And I think that that's wonderful because, you know, obviously, I think it's some of the most delicious Kool-Aid I have ever tasted. And I'm a huge fan, obviously, of clinical quality management and everything that that we can do together. So let's dive in here. So, you know, Jamie went through and talked about the different OA domains. She also talked about the common threads and common elements across OA domains. Now I'm going to look at this a little bit differently. Let's look at the OA and Achieving Together and think about the way that OA domains tie to Achieving Together. So it makes sense. The workforce engagement piece, the CQM performance measurement piece, the quality improvement piece, the consumer involvement piece, how we achieve outcomes, and the HIV care continuum are all highly aligned with what we have within Achieving Together. So let's take a couple moments and dive in here. And as Jamie had mentioned, and I think Julie as well, we're talking right now about the AA level, right? And we've mentioned the provider level, but it's important for us to remember that in this training today, we're really talking about our system and the AA level OA. In coming months, we'll actually have 4 more sessions tying Achieving Together to provider level CQM using their data and using OA results from the provider level. So that's something to look forward to, that we have this granular provider by provider way of thinking and tackling this. But today, we're going to keep our thinking at the AA level and what we do as a system for our regions. So here is our Achieving Together framework that has a central goal of preventing HIV transmission and acquisition, increasing viral suppression, eliminating health disparities, and cultivating a stigma-free climate. There are a lot of different activities that surround this goal, and a lot of different elements that play into those activities. And those elements include community, empowerment, social justice, integration, and equity. But really what we're trying to do here is to address the main social determinants of health and those characteristics of the HIV population that we serve and maybe that are prevalent in our areas if we're not serving them yet, so that we can have this really good concrete understanding of what are the service needs in our area, what are the needs of the HIV population in our area, and how can we meet all of those needs by providing efficient and timely services to people living with HIV in our area. So by 2030, we have a combination prevention where everyone with increased vulnerability has access to the different interventions that will be suitable for them, whether it's condom or PrEP or PEP or anything that is really meant to address the issues that predispose people for HIV and also early identification of people living with HIV. 90% of people living with HIV are diagnosed. 90% of people who are diagnosed are on ART. 90% of people who are on ART achieve viral suppression. And this should mean a 50% overall decrease in incidence of new cases of HIV based on this plan. For combination prevention, in terms of thinking about the crossover between the work that we do in HIV treatment and how that lends itself to combination prevention, I think is very important. The agencies that we fund and provide in our regions aren't funded in a vacuum. They're funded because they're part of a system or a network of care. They're an important fiber in the fabric of the safety net that we're creating and funding within our regions. And so it's really important for us not to just have us, when we're doing Achieving Together and when we're doing US-EHE, we don't want to just have our Ryan White hat on. If we only have our Ryan White hat on, we're going to miss the ball. So we do need to think when we ask questions about quality support, who's involved for stakeholders, what types of resources are available, what type of measures do we have in place, what type of QI projects are appropriate to improve performance. We can and should include combination prevention and these aspects alongside our treatment pieces. And when it comes to the overall HIV care continuum, we can't forget the importance that prevention plays. I see Julie has shared the link again for achievingtogethertexas.org and her note that status neutral approach is really key to ending the HIV epidemic. We can't afford to just have our Ryan White hat on. We have to, think about what mechanisms are available at the very least to include prevention in our quality program, because these services are being provided together in the community together. We can't afford to keep them in silos and vacuums from each other. So this is the diagram for Achieving Together. I'm sure that you've seen before in terms of thinking about our status neutral approach. When it comes to the different processes in place for HIV prevention continuum and the different processes in place for our HIV care continuum. This framework is really great in that it includes the different key social determinants of health that are important to the state of Texas in Achieving Together, and likely are very important to the Texans that you serve within your region of the state. And in terms of thinking about some of the key words, activities, and approaches that we take to doing Achieving Together from a quality standpoint, such as thinking about integrated care, right? What are the main risks for ongoing HIV transmission? Unaddressed mental health and substance use. So we have to find ways to make sure that we have a sense of what types of integrated care our clients really need. In addition, we should have a sense of what types of integrated care our clients are really looking for. Sometimes what we need and what we're looking for are different. And what do we know about people? People are free to make choices and they can decide, I'm not interested in coming to your clinic. Thank you very much for your 11th flyer. No, if your services aren't provided in a way that are acceptable, appropriate, of interest to the clients that you serve or would be additional clients that you serve, then you're going to have a hard time attracting and maintaining those clients. So I don't want to spend too much time going over this diagram, but just looking at the words that are included here should be a good starting point for you to start having discussions internally with your data folks. What type of data do we have available? Can we look at the extent to which we have comorbid mental health and substance use issues in our HIV population? Can we look at the extent to which we have unstable housing or other housing challenges for our clients? And how does that play into outcomes? It's a really, really good approach to thinking about how Achieving Together and the framework of Achieving Together plays into quality and how quality plays into Achieving Together. So we had that list a couple of slides ago in terms of the ways where the OA really aligns itself closely or neatly with Achieving Together. So stakeholder engagement. Well, so much of our work, by definition, when it comes to Achieving Together and EHE is rooted in the community. In fact, EHE's #1 thing is this is about community planning in HIV service systems. Full stop. Almost all the different metrics, operational metrics are about how you're involving community substantially in HIV service system planning and discussions about the HIV service system. So it's really cool that the OA has this way for you to look at, well, how are we doing with this, sis? Are we doing good at working with the community, or are there opportunities to be more concrete with the way that we involve the community? Do we involve more than just the providers in our hopper? Are there opportunities for other folks that we don't fund perhaps to also weigh in as service providers as part of our network or part of our healthcare neighborhood? Are there opportunities for the people living with HIV we serve and their antecedent communities? Thinking about a status neutral approach, right? People living with HIV don't just fall from the sky. You know, I myself was a young gay man who was having fun. That's how I became HIV positive. You know, so thinking about, you know, the different risks. So like, you know, if there are lots of students becoming positive, like what do you do with universities? What do you do with schools? Right? So thinking about so much of our work is rooted in stakeholder engagement that it's great that the OA has this whole area for us to stand up these activities. Thinking about workforce engagement is a specific type of stakeholder engagement that's beyond the people living with HIV. But really what we want to do here is to include information that helps us to drive onward progress. So planning and evaluation are really key to engaging stakeholders because you're talking to them about what their role is, what the result of their role is, and how what they do plays into a bigger picture. That stuff is usually gold to organizations to be able to provide that story to them and to be able to talk about how your AA fits into the full state picture, I think is really important as well. So thinking about, again, this is stakeholder engagement at the AA level. Really what we want to do here is avoid rubber stamping. We want to create dialogue. We want to create a space where people feel and understand and know that their words have weight. It's not just, here's a presentation and we're going to go, when people share their ideas and their thoughts and ignore them. Ooh, that's the best way to make sure that, you know, you're not going to be successful. You need to let people be seen and heard and to feel seen and heard in these types of activities. And again, that's the purpose of Achieving Together and US-EHE anyway. So we have our Texas Part B required CQM performance measures. We've shared this with you before. So lo and behold, the CQM performance measures that the state has selected are all focused on Achieving Together goals. Huzzah! So by collecting this information and describing it in this way, we're already meeting marks for Achieving Together just by following other expectations that the state has set for us. By passing these expectations down through to the subrecipients, then you're really helping the state to aggregate what's happening across all of its diverse regions and what does that mean as a whole. When you have segmented information or other types of disparity information, stigma information, satisfaction information, that too is rolled up all the way through the AA at your level to the state. And it really helps the state to see where there are key populations that need specific types of help. There are no silver bullets, especially in a place like Texas. You're huge. You need to have that level of granularity. You need to be able to see where specifically to act and what actions need to be taken. And so it's wonderful that the state has already provided this framework for us to be able to do that as a part of other broader expectations. So use the data. You know, that's why it's part of the plan, right? Like, and that would be how you engage your stakeholders. Establishing a data collection system as a means to the end for achieving together. You can engage the providers in your network in your region to talk about optional performance measures beyond what is minimally required. And it's important to be creative, especially when we think about our status neutral approach. There may be some measures and some types of activities that are more relevant to some groups than others, and that is okay. And it's important to do this as, again, remember the buzzword we used last time was discovery for QI. This is part of discovery, to have this place where you're looking at specific concrete information and engaging people in dialogue about what that means. So again, it should be a central means of engaging people, whether they're provider organizations, even people living with HIV, I would say, to help identify change ideas, describe progress, identify next steps that will help you to advance your Achieving Together agenda locally within your region. And then lastly, to identify qualitative data sources to add context to the quantitative data sources. Aries does a lot for us. You know, as we move beyond Aries in the future, that new system will do a lot for us too. So it's really great for us to think about what we can do in addition to that, you know, in a light way, a light touch. Again, we don't want to be public health run amok. We don't want to make people's lives miserable, but we do want to get enough contextual, nuanced information to help us understand what's really happening behind the surface of those numbers that we get out of Aries quantitatively. So using data is another really key way, important key way that the OA lines up with Achieving Together. Recommended QI activities. So Achieving Together includes many hints on where to look for those QI projects. The framework itself has all the buzzwords, right? But there's an opportunity, I think, for you to engage folks locally within your region around which ones are the important ones. We talked about integration, income stabilization, stigma reduction, housing, food security, other supports, you know, for people that feel vulnerable and isolated. The sky's the limit here. But it's really important for you to talk about this with the providers and consumers within your regions about what is the most important one, what holds the most water, or where do we have the most need. And again, thinking about the really expansive big regions, understanding that you may have different pockets of need in different areas. So being open and willing to explore these possibilities with folks, I think is important. And again, to Bob's question, even thinking about maybe starting, if people are really itching and worried about the data, start with start with domain C. It doesn't need to be A, B, C, D, E, F. Start with whatever one is going to end up being most important and kind of like release the pressure from people. You want them to go, ah. You don't want them to go, oh. So think about how you can take what are the passions that draw them to the work and to explore those areas using these recommended QI projects that come right out of the framework. Consider supporting a region-wide QI project, but again, thinking, you know, about our larger, more expansive groups that, you know, don't have the Part A core, you need to allow for some flexibility. So even thinking about the way that the state DSHS has crafted its QI project to be open, to allow for you to identify the specific activity that will make the most difference in your region. You can think about the language that is included in the contract rider that comes from DSHS and think about the way that they describe that to leave that similar openness for large expansive areas. Now, for those of you that have a Part A core or that are perfectly aligned A, B together, that's less of an issue for you because you have more that dynamic going where people are used to working on same things or working on two different sides of the same coin. It's all about flexibility and it's all about what's reasonable and practical based on the needs of your region. The most important thing to think about when we do a QI project, even when we allow for flexibility, the only thing we won't be flexible on is that no one is allowed to say no. You sign the dotted line. you are part of this system, you will do a QI project. You will do a QI project. Everyone does a QI project. No one can say no. Even big agencies that are like, but I don't wanna, I'm too big, it's too hard. I'm sorry, the answer is you will do a QI project. So I can't emphasize that enough. And in terms of thinking about how you can crosswalk the organizational assessment into something for compliance monitoring, that'll be a conversation that we include in our next 4 sessions. But we do have a way to concretely think about that and how to compel people to move on this, even when they really don't wanna. Okay. We're at our question and answer. So I hope that this has been an interesting way to think about this. Again, this is at the AA level, not at the provider level. So we'll hold our questions for provider level applications later, unless it's something that you think it's impossible for me to think about this at the network level if I can't think. You can ask questions like that right now too. But we're really interested in your thoughts about the connection between Achieving Together and CQM programs and how we can use these activities to drive our progress in achieving together. Nora's gonna quote me. Quote me. Go for it.
It's recorded.
Julie, what do you think about the connection that we made? Are there any areas that still seem fuzzy?
So I think the presentation has been amazing and you did a great job breaking it down piece by piece. I don't find it to be fuzzy, but if anyone does, please speak up.
These are the important issues of our time, right? Like Achieving Together and US-EHE. Damn if we haven't been trying to do this for decades, you know, and I feel like we've really gotten to the point with our frameworks that we've become so much more sophisticated.
I mean, I'll just add, you know, with the AA level OA, right, that is a systems viewpoint. And so as we think of Achieving Together, US-EHE, like a systems framework is going to be important, right? Flexing those ways of thinking are going to be hugely helpful. So I kind of like that connection between all those pieces as well.
Absolutely. So some of the things I'm going to be working on around linking Achieving Together in our CQM program is building some champions on the prevention and care side. So we have direct handoffs for when someone's tested, so we can really facilitate rapid start, and that will help viral suppression and will help ultimately end the HIV epidemic. So you'll be hearing from me, those of you who also are funded for prevention. We're also really doing a lot of trainings on stigma. San Antonio has a wonderful community group called the End Stigma End HIV Alliance, and they have put together healthcare guidelines or anti-stigma guidelines for healthcare organizations. They're going to present with us tomorrow at our fundamental session. And then I know the PRISM Healthcare of North Texas has also done a lot of work around stigma, and they have some resources that I'll be sharing with you all over the next couple of weeks. We might post some of it on the Achieving Together resource site. So if you all have anything you'd like to share, you are welcome to present at our next fundamentals or any upcoming, not the next one, but we have the calendar open for 2021 and beyond. We'd love to have whoever has great work going on, they can share with others. Some of the other things we're doing is trying to make sure we have the performance measures for ending the epidemic. They actually are calling them indicators, kind of the same thing. So you can easily get that data of, was a person linked and received labs and hopefully medication within 30 days, which is one of the EHE indicators that wasn't in the HAB-QM standard toolbox. You could mix and match reports to pull that data, but we're trying to make it easier. So hopefully those kinds of things will help. And then just collaborating like we're doing now. I wish people would be more willing to talk this morning, but I know it's been a rough couple of weeks and it's Monday, but
Case of the Mondays.
Anybody have anything to share?
I was gonna bring up that one of the things that we need is linkage to care data, because we're just a Part B,
Mm.
and we're all spread out among, you know, the 64 counties or whatever. But just having some kind of idea about linkage to care data would really help us look at focuses for, to end the epidemic and all that, achieving together stuff. So
Absolutely. I think that's where our issue's been on the care side, is we don't always get the testing data. And we're not allowed to have it if they're not already in our system of care. So trying to figure out all those barriers and challenges. And the only way we can do that is from hearing from you guys to know what those challenges are, because we're at the state, or now some of us at our home offices, trying to figure this stuff out makes it more challenging. But you're right, Bob. So that's what we're trying to do. But then at the state, we have to scrub and clean the data before we can share it. So like right now, it's 2021 and we have linkage data, but it's from 2019. So hopefully maybe our new system will facilitate more real-time data. We'll have to wait and see. But if we can establish those relationships with the prevention folks, then we should be able to do that without a data system. Like we can use an Excel spreadsheet if we have to, right? Or things like that. We gotta figure out and think outside the box sometimes till we get our processes in place.
another thing that exacerbates this problem is some of the public health departments just don't want to fill out MOUs with our providers. I don't know if anyone else has encountered that, but that was a major problem this last year. Just getting MOUs to share data among, because you have to remember, our providers, only one of them, well, Project Vita's new, and LaFay, they have clinics attached. Everyone else is just an agency with no clinics. So they're facilitating data, they're setting appointments, they have to find places to get care and all that. And so just having some kind of, but they were having problems with getting MOUs from the public department or public health departments locally.
Well, that's something we might have leverage over at the state health department. So thanks for bringing it up. We'll talk with Janina and see what we can do.
Yeah, I love that, because, you know, there's going to be some things that the state can facilitate and streamline. They can grease that wheel. But then there will be other things that are, you know, based on the way that rules or even regulations are crafted that prevent them from making changes. And they also, because of the way that systems are set up, they have a hard time advocating for certain types of changes. So these discussions in this way allow everyone to come together to talk about what are those lowest common denominators, because sometimes there is power to the 7 AAs coming together and having a joint letter to the state, or other key consumer or provider groups, hospital associations. You know, each of us in our own way, our own stakeholder type, have different buttons and levers that we can apply to the system. And so by having these opportunities to come together to collectively share, then we can find out what those buttons and levers are. And we can find ways to discreetly and appropriately farm out those tasks so that no one steps on any landmines, and we can do some really great work together. Thanks for that. So Jamie's giving like definitely a thumbs up to that concept too. So this takes us to the end of our presentation. And what I'd like to do, as promised, is to show you some of those different templates that we've created that'll be in the toolkit. So you can see this one here is called, if my technology will cooperate with me, this one is called, insert your name, Clinical Quality Management Program Subrecipient Requirements. And so you can see here, this is a tool that you can use when, and this is the kind of thing that you could slip into an agenda. You can make a nice slide. It even go into an FOA in terms of the type of things that you're going to be expecting of people on what timeline should they join your network as a funded provider. And you can see here, these are just placeholders. It could be anything that you want or need it to be. But the different groups we have here, the Clinical Quality Management Program, Quality Monitoring, Planning and Evaluation, and Training. And you can see that there's different groups that are included here that have different timelines. So this template will be one of the ones that you have available to you through the toolkit. This gets to the training question that Nora had asked earlier in terms of how you get people to participate in these larger activities. And so again, similarly, these can be anything that you want or need it to be. This is thinking about the CQM team and what they need in their first days, their first weeks, ongoing in an annual fashion. Your division directors within your AA and the managers of your AA, because they're a special set of stakeholders, right? They're the ones that are really helping to drive programming, to drive support and process. Then we have the frontline staff. So this is going to be likely folks that are managing contracts. And again, I understand the 7 AAs are very different. So you may not have all of these buckets even, and that's okay. We'll think about what is relevant and important to you and the groups that you have. Planning council members could be the fast track group, could be an Achieving Together group. You may not have one like this, but that's another group. The external committee members, the funded service provider organization, and consumer advocates. So thinking about the type of information that each of these groups needs in their first days of being part of the HIV system in your region, the first weeks, and the things that they need on an ongoing basis. All right, and then the last thing I wanted to share is that basically we have a bunch of different examples for websites. And Julie shared the new website for Texas. But when it comes to achieving together in EHE, communication, communication, communication. Communication is how you engage people. It's how you inspire people, right? So it's really important that we have a place that's the place that people can go to, regardless of what their role is in our service system, to identify information. So those websites there are all, and we'll add, that's a great point. Jamie just private messaged me that we need to add Julie's new Texas Part B link to that. So you have that as well. But you'll see when you go through and click, you can design it any way you want, whatever works best for you, whatever works best for your stakeholders as a communication tool. Really, that's what we should be focused on there. All right, so just quickly a reminder of the different types of resources that we have available to us, heavily referenced in today's subject matter and call materials. So definitely give those a click through. And we will hopefully have more information for you within the next month or so. I know that y'all are having a meeting next month with Julie's team, and it's a statewide meeting. And I believe that we're going to be able to have more information.
Actually, we're not going to have that meeting after all. We're under a new division of leadership, and so we are not going to have a spring contractor meeting. And I apologize for not sharing that earlier with everyone. But we'll let you know when our next meeting will be, as soon as we can. Sorry about that.
Oh, no worries. But even so, be on the lookout for the new series to be announced sometime in April. And we're looking to do them about every other month. And they'll be about 2 hours as well. They'll have breakouts in them to allow for the different AA types to really be able to explore these issues together, because it's important for us to recognize that the key differences across our regions should be something that is a strength for the state and is not a distraction or a weakness. So that will be emphasized heavily in the next 4 sessions. And those will occur roughly between May and November. And thanks so much. While I'm pulling up the polling questions, I don't know if there were any other questions that came while I was wrapping up here.
Nope, I think we're doing good. It's been a great conversation.
Yeah. So just take a moment, please, to fill out the evaluation. There will be an evaluation survey that we send out after today's session that actually looks back at all 4 sessions that we had. We want to just make sure that we have all the information that we need as we roll into the next 4 sessions so that we can plan this well and make sure that we're meeting your needs, that we're not spinning any wheels or wasting any of your time. We know that you're busy and we really value your contribution. Great.
And if you think of anything after the meeting, just email me. I believe everyone has my email contact information or phone number. Thank you, Michael and Jamie. This was amazing, a 4-part series. We learned so much and look forward to the next 4 as we go through the next part of 2021. Thank you all for joining us. Again, these will be on our website in the next probably a couple of days for this session, but all of our 3 previous sessions are already up there. I just checked and the website is live, and we'll be adding more tools now that we have a place to put them. So thank you all again. It's going to be a great year for CQM.
Got that right.
Yay, thanks everybody.
Have a wonderful rest of your day and a beautiful week. Take
Happy
care.
Easter.
Oh yeah, happy Easter and Passover. Bye, Gina.